Okay, we have
Hello.
hello. We got 4 of us here. We need
Sorry, I had to do my 2-layer Google authentication. They need you to download the YouTube app.
goodness gracious.
They actually make you download the YouTube app. I'm like, what? Isn't that crazy? I don't know. Something fishy's up, but
Okay, well, we're missing Caitlin, but I think we should go ahead and get started here. I'm Kristen Dickerson, and was one of the founders of the Houston chapter of the Free Market Medical Association. This chapter was one of the earlier chapters. We've been around 5 or 6 years, and we've gone back and forth to in person and some online. But this was a topic I think deserved to be heard, because I'm having problems with it, managing it in health plans. There's Caitlin. And it's something that there's been a lot of change in technology. There's been change in our ability to process big data. And so I think breast imaging is a topic that really needs to be in the forefront now. And we've got to figure out how we pay for it and how we, don't overutilize it, don't underutilize it. And so I think it's a topic that bears some time and attention. I'm going to let my Ava, will you advance to the next slide? I am a 30-year mammographer from Houston, Texas, and I own a company called Green Imaging that offers medical imaging and other outpatient testing across the country. We actually work for, self-pay patients, but primarily through health plans, through self-funded health plans, and through some new innovative health plans. And so I'd like for, everybody to, and I'm also a woman, and have a mom and sister. And so, I think if each of us introduce ourselves and what our specific perspective is on breast imaging, and then we'll move along to the questions at hand. Nancy, you want to go?
Sure. Thank you, Kristen. I am really thrilled to actually be participating in this panel. So my name is Nancy Giacalone with Olympic Crest Insurance. We're a boutique employee benefits agency out in Gig Harbor, Washington. So clearly I am a broker, and I see these issues both from a positive and a negative standpoint on the brokerage side. I am also a woman with breasts and issues accessing mammography services. So this is a very important topic that is near and dear to my heart. So thank you for having me.
Hi, so I'm Dr. Paula Muto. I'm a vascular and general surgeon for over 25 years. I've always been a tremendous breast women's health advocate. I was luckily trained in the era of Susan Love and the original breast clinic model at the Sagoff Center. And so I've always had in my practice, even though I do vascular surgery, I've always taken care of women with breast issues. So I think over the past 25 years, I've always felt like it's not that hard to navigate a patient quickly to what they need. And so that's always been my passion. I've started 4 breast centers. I'm like Dr. Dickerson, also an entrepreneur, and trying to disrupt the system with my UberDoc platform, which is, strangely enough, is about finding access to specialty care immediately through a cash pay model that is just price transparency access and just take good care of the patient. So I'm actually thrilled to be here because I think that I have a good experience with breast patients, as well as sort of like a motivation and an experience with trying to make it easier, make it better, faster, cheaper, and better for women.
Thanks, Paula. And Al, would you like to introduce yourself?
Yeah, sure. First of all, can everybody hear me through my speaker here? Hello?
Yes, we can hear you.
Oh, okay. All right. So I'm the data guy. I wrote 2 books on this topic. I think several of you have read, or at least purchased them or were given them. Why Nobody Believes the Numbers and Cracking Health Costs. So it's my job to actually sort of look at the hard data of these things, and this is what I did for years and years before starting Quizify, where we teach people how to look at the data for themselves and for their families.
Okay, and Caitlin?
Hi there, honored to be here. My name's Caitlin Christine, and I'm the CEO and founder of Gabby, where we're on a mission to eradicate late-stage breast cancer. So it sounds like there's alignment with everyone on this call, but Paula, I resonated with what you were saying in terms of getting patients to care quickly and providing high-quality care. And that's exactly our goal at Gabby, is acting as a woman's virtual breast specialist, assessing her risk for every patient that comes through the door so that based on her risk, we are guiding her to the appropriate care for her risk level, which of course means the right screening at the right time, at the right cadence. And I am obviously an entrepreneur and passionate about breast health, but that all comes from my own experience as a caregiver, losing my mom to a delayed diagnosis of breast cancer, and then my own breast cancer diagnosis when I was in my early 20s.
Well, thank you all for being here. I think, I think we have a spectrum of thoughts on this topic, and I'm really excited to cover, these questions. The first one I'm going to ask is, what regimen for screening for breast imaging do you see the data supporting today? And, I've been doing this 30 years. I've seen changes, in the types of cancer, the stage of cancer that we're diagnosing. And over time, I've seen changes in our ability to diagnose it over time. But, what I really recommend is that we, that women get at least a 2D mammogram every year. The 3D mammography, I think a baseline should be 3D. We establish whether or not they have dense breasts or not. If they don't have dense breasts, there is no improved sensitivity of 3D mammography. They can move through the 2D cycle. If they do, we continue to provide 3D. And I'm thinking of this as an employer, as a health plan. The other thing is with breast MRI, unless you're high risk, or you're staging for a cancer, there's no indication that it's more sensitive. So that's my personal opinion. And, from assessing the data, I know we'll move along to everybody else's and get your feedback. Nancy, from the side of a woman and a, healthcare benefits advisor, what are your thoughts?
I agree with you, Kristen. I do see a lot of people saying, oh, I need this without any clinical substantive data behind it. So they're saying, I need the MRI or I need the 3D, and there's nothing that supports that. And then they get mad at the insurance company or the plan or whatever when they say, actually, you don't need that. And they kind of come back and they're angry, be like, how would you know? Well, again, I think that we need to be more clear in explaining to patients what the data supports, when you need to have it, what you need to have, and how frequently you need to have it. Again, as a female in my 60s, I would prefer not to have a mammogram every single year. I prefer to have it every other year. But I was told I need to do it every year because I'm on hormones. And so that puts me at a higher risk. Totally understand that. But why aren't we having those discussions up front? Why do I have to wait down the road to get that information? I should have been told that when I was prescribed the hormones. So I think there's just so much education around this.
Excellent. And Al, your thoughts?
That hormones thing, we actually have that in Quizify, that there's certain questions you need to ask because you're not going to be offered the information. So I'm completely on board with what you're saying. In general, I'm more of a supporting the U.S. Preventive Services Task Force recommendation because they're of they've sort of made a balance. It's not a cost thing. They've made a balance between the false positives, the likelihood of finding something where, in fact, the progression can be changed by early diagnosis. They spend a lot of time on this. I knew somebody really well who was on it for quite some time, and she told me about how they went to the 50-year-old level and how, in general, ties go to the providers. Ties go to doing more screening because they said, honestly, it's much easier to counter people. There's basically a lot of people whose livelihoods depend on screening, and they just don't want to get into it with them. So if it's close, they go with more screening. The other thing is, now you've described being at high risk, Nancy, which you are. You would not have been had you been on Quizify. But if you're at typical risk, meaning no BRCA, no hormones, no family history, no exposure to some kind of carcinogen, no personal history, I'm looking at this study that just came out, this massive study with 9 million people that found essentially no benefit to in all-cause mortality for screening. So we just kind of say go with the USPSTF unless you're high risk, and then go with what you and your doctor decide.
Excellent. And, you know, I think we do also need to, I'm going to add a question. And those of you who, Caitlin and Paula, you can answer this as well. But what do we, you know, outcomes data is, it can vary. You know, is death the outcome that we're trying to avoid, or is advanced stage cancer what we're trying to avoid, especially in 40 to 50-year-olds where it's usually a more aggressive cancer? So Paula, I'll let you take that.
I think that's a great setup. So I'm going to give you the historical perspective. So in training, we came out, we were imaging people 50 and over, mammography. I worked with, you know, where I was training was the Faulkner, where Norm Sadowski was kind of the first radiologist that was doing all of this, like, you know, screening mammography and coming up with the original recommendations. So 50 and older, and 50, I think, and it went to age 70, right? I think, Kristen, the original studies were like 70 because that's where people's life expectancy was. And so it was an annual mammogram, and it was annual because essentially it just was easy. It was around your birthday. I don't think there was any great data about 16 months, 14 months. It seemed right to be 12 months. So then during my course of my practice, what happened was that people started to think, well, let's roll it back to 40. Let's do mammograms between 40 and 50. And I'm going to tell you, as a surgeon, we did see a lot of patients that had a lot of sort of unnecessaries. And it was always painful because you went to a breast center and you'd go and talk to the radiologist and they would say, I would feel more comfortable if, and I'm like, it's not about you feeling more comfortable. It's about the patient feeling more comfortable, because they hold their breath when I go in and say, you know what, we need another view, or we need to put a needle in something. Like, you don't understand. And so I completely understood where the task force was coming from, where false positives were problematic. Okay, I get it. In what happened since is digital, I mean, analog mammogram gave way to digital mammogram, and that was a huge change. My radiologists felt less anxious and were better at reading, okay, because it was just a better image. And then 3D sort of on top of that. And then it was sort of like we were doing all this 40 to 50, and then unfortunately a lot of doctors stopped ordering mammograms. So they brought me into the family practice residency that I work with, and they had stopped, and we had a point counterpoint about this. Task force says no mammography. And I said, so we asked that question, Al. We said, is the outcome actually mortality? You know, but really what it turns out is that the cost of managing a patient who has a small ADH, atypical DCIS, okay, versus waiting for that patient to develop that stage 2 cancer that has a lymph node. Yes, because of our treatments, the outcomes are the same because our cancer therapies are so good, we can get everybody to the finish line. But how you get there is painful and expensive. And it's way easier, like for myself, I get a colonoscopy, I have a cancerous polyp. I would say I would get a colonoscopy every year rather than some hack surgeon like myself taking a piece out of me. Not that I'm afraid I'm going to die of colon cancer, because of the inconvenience, the cost, the pain, and the potential complications for having major surgery. So I'm going to tell you that adding cancer therapies are so different now. If you're stage 2, it's not like you get tamoxifen for 5 years. You get stuff for 10 years. Herceptin is a 2-year treatment. Like, all of these therapies are so much longer and more complicated for patients that if you find them earlier, it is cheaper to treat them. So removing a polyp from the colon is much better than waiting for it to become a cancer. So using the endpoint of mortality for breast cancer and in 2024 doesn't make sense anymore, because we can get everyone to the finish line with metastatic disease. So it's just how painful is that journey and how expensive it is. So my feeling is with screening, I like it where it is between 40 and 50. You judge it on risk. You know, you look at this, we have a lot of other testing we can do now. I do believe breast cancer is 2 different diseases. I felt this way for a very long time. There's some people who are that early, you know, that stage, you know, the little polyp to colon cancer sequence, the 7-year sequence, the calcium that develops into this and this and this, and it's a 10-year sequence. And then there's these people that just jump on the scene. We are seeing a lot of these people jumping on the scene now. Triple negative disease, we never talked about that before. I'm seeing more of that. in younger patients. I don't know what that's in the water supply or something. So I feel like the more information we get from data, we'll be able to decide what women needs to be in the the screening 40 and 50 sort of range, and then maybe every couple years and every year at 50 for sure, because that's where the risk goes up exponentially. And then who can sit in this other range of the higher risk? Who needs that MRI? Who needs that 3D? Who needs that? And I think the genetics will give us the answer to that. And so that's kind of where I'm coming from totally as a clinician.
Yeah, and that's a great lead in for Caitlin and what she does. And, I would also say that 40 to 50 age range as employers, those are frequently women who are employed. A lot of them are single moms. Think about the effect of a later stage diagnosis on that age range, the lost time from work, the expense of that for an employer. And so I think, all of this weighs into this benefits world where, Nancy and Alan, Paula, and I all live. Okay, Caitlin, love to hear from you.
Thank you, Dr. Dickerson. I think, first of all, I just have to say, Dr. Muto, amen to everything that you just said. And for me, kind of to summarize, and this is certainly what we believe at Gabby, is that it all starts with knowing the patient's risk. And so, I mean, one of the things that we were really excited about was when the ACR came out with a statement earlier this year that every woman needs to have her risk assessed by the age of 25 in order to determine if mammography is the right screening for her and if she should start earlier than 40. And so everything that you called out, Dr. Muto, of, if a woman comes in and says, I want an MRI versus a 3D mammogram or this, that all comes back to, what does the patient understand? Has the patient learned the difference between those different modalities? And also, has the physician learned the patient's risk to properly communicate based on your risk level, actually, you need this, or you don't need this? And that, of course, informs her care along the entire process. And of course, I think mortality is the absolutely wrong benchmark to exactly your point that you called out, Dr. Mutro.
Okay, great. Well, one of the things in health plans that I'm asked to assist with all the time are how do we make sure our members, our employees are getting the screening that they need. And so I'd like to ask, I think, Nancy's already shared one issue with me about, barriers, but I'd love to hear everybody's take on how we, what are the barriers they see and how do we get past those? And I'm going to throw in that one of the barriers I'm seeing is the fact in a MEC that the screening mammogram is covered, and the woman with a lump in her breast who needs a diagnostic mammogram and an ultrasound is not covered. And the problem there is what we're seeing in the claims data is that ultrasound now costs $1,300 one side, because breasts are two different things with ultrasound. Whereas a mammogram, it's bilateral and it's one price, and that's going to be in the $650 range. So somebody's going to have to spend $2,000 out of their pocket just to get this diagnostic mammogram and ultrasound handled. So that's one of the barriers that I'm seeing. Nancy?
Yeah, I have a couple of thoughts on this. First of all, don't love any sort of MEC plans, and just for those exact reasons. There's too many variables that people think something's covered and it's absolutely not covered. But I also, one of the things on your slide is, how does genetic testing factor in? And I'm one of those people that believes the more knowledge, the more better. So as soon as, I don't know, 5-6 years ago, I actually had genetic testing done on myself to find out if I had the breast cancer gene and, to take that into consideration. I shared that information with my physicians, and they literally didn't give it any consideration whatsoever. And I think that's a problem, because that's really valuable information that some providers are taking seriously and some are not. And it should be factored into the type of testing that is done, because it is a small cost for long-term information.
Okay. Al, do you have any thoughts on this?
Yeah, I actually did a whole webinar on this topic. You typically, an employer will usually, I don't know, pay somebody $50 to go get one of these things or something. And that works great for salaried people and people who work at home. But what nobody ever, and by the way, I still think this is done too often, but that's a different issue. But let's assume you want to do it. Okay, so this is all under the assumption that you want to do it. What nobody takes into account, and I literally mean nobody, we did a poll in our webinar. We had about 180 people in the webinar, and there was one person who said yes to this. For hourly employees, even though you're maybe paying them $50 to get a breast screen or something, you are counting the time away from the office as PTO. You're not paying them for that time. This discourages all sorts of screenings, of which this is one. It would just be very easy. You know, people always talk about health equity, yada, yada. This is just the easiest health equity issue to fix, and yet nobody does.
Okay, Paula?
So the barriers, there's a lot of barriers. So the sum of the parts is greater than the whole. This is what, when we started doing breast clinics, the idea was get the patient in. If there was an abnormality, do the spot, do the ultrasound, try to get that answer as quickly as possible, right? That was that you wanted to compress that time frame. And you were able to do that very nicely in breast centers at the beginning. And then the billing issues started to come in and the coding issues started to come in. And I used to see patients coming to see me for their annual cancer check, and they were getting their annual mammogram, but because they had a cancer diagnosis, they were upcoded to a diagnostic. And then they'd get a bill for that. It would drive me bananas. And it's one of the reasons I went to blows with many of my people. I said, that's gouging. That's price gouging. Plus, they would start to charge a facility charge on top of the visit, on top of the mammogram. It's like, well, the whole point of me being at the breast center when you got your mammogram was to make sure that that patient that's high risk got to see me at the same time as their mammogram. So I started to go to another radiology center, one of the first sponsors of UberDoc actually, and I would see patients in the bone density room just to the convenience of the patient because I didn't want them to get that third charge. So these are the barriers. The billing is the #1 barrier to good breast care, because we've now derailed, and it's now like, well, what's going to pay? I do free ultrasound in my office. Okay, I do free ultrasound for patients that have like a cyst or whatever, because I do ultrasound my leg. I have a great ultrasound tech. I'm not certified in my ultrasound. I don't even bother billing it because it isn't worth the billing, because it doesn't pay a lot. I mean, Medicare, I think in the office, I think pays like $60 for an ultrasound. So I understand that in the hospitals and other centers, it's a higher, and it's way underpaid because, oh, I'm going to tell you, breast is underpaid, period, end of story. Anything women's health is about like, is 30, 40% less reimbursement than everything else. So just the fact that we're even arguing about a mammogram cost is sort of part of me. It's like literally the lowest on the totem pole in terms of reimbursements. So in general, I think the barriers have to do with billing. I think that now we've created obstacles so that people have to go through these steps. A patient now comes in for their diagnostic, they can't get an ultrasound the same day because insurance is going to pay for that. And I think that is unfair to the patient, like resoundingly unfair to the patient. So that is what I see as the barriers. And I think that as we become in a more transparent world and employers begin to understand there's ways to be able to get around this with just direct pay and cut the nonsense, we be able to go back to the ideal, which is basically take that care of that patient the moment they walk through the door and let them leave with an understanding of what the diagnosis is. Because the series of billable events over a period of 2 to 4 to 6 weeks doesn't help anyone.
Yeah, and I would add, that's one of the problems I'm seeing in the market. We're scheduling, patients at imaging centers all over the country for their breast care. I see abuse. These private equity-backed mammography, groups of, 500 mammographers, really, because I think that it is under reimbursed to some degree. They will not let you get the diagnostic mammogram without an ultrasound, or, they promote it onto an MRI same day. Over and over again, we see, rates of MRIs at these breast centers being, or the numbers, the percentage, very, very high, much higher than we see in an outpatient practice. And so I do think getting the financials lined up with the care, it may be kind of a capitated thing. You come in, this is the bundle you get paid for breast care for this patient for a year, and that might be a solution, and it's a fair amount, and everybody takes home a fair pay.
I actually spoke to a woman who runs a breast center down in Florida, like part of Ascension, and she actually said, "Oh no, we can't do the diagnostic on the same day because it's too much radiation." I'm like, "What?" So somebody so they're making up stories, they're making up reasons why. I said, it's because it's not going to get billed. Like somebody thinks they can't collect on it. And I should just say one note on the genetic testing. Years ago, people came in the offices and said, hey, Dr. Muto, buccal smear all your patients and get this genetic test. And I was like, I'm not teaching that with a 10-foot pole, because what am I going to say when you're negative? Oh, you're not going to get breast cancer? So I always use my genetic testing when I send patients, is because I've taken a history, they have a reason, and I send them right over to the oncologist, because it's a complex discussion of what those genetic tests are. But they were pushing those genetic tests like, hey, no big deal, here it is, right? It's really easy to do. But just as a clinician, I was like, I'm not touching that.
Well, and on that the radiation piece, what I see is somebody's already had a bilateral screening mammogram. They want to do a bilateral when the patient goes back for a diagnostic. That they're just going to be repeating the same thing that was done. So that's another abuse that I see in the system. Caitlin, you want to weigh in on this, on the barriers?
Yes, the first thing I would say, from not being a provider, but what I see, what we're hearing from patients, and then even as I go in for my own care as a patient, is that there's confusion amongst the guidelines. Are you following the American Cancer Society or USPSTF or the NCCN or ACOG? And everyone's saying different things, not to mention, oh, did it change this year to 50 or did it change to 40? Or did that happen 10 years ago? So that, of course, is how a provider is choosing to practice care, and that's translating down to the patient. And if providers are confused, of course the patient's confused. And then secondly, I think the providers have been put in a position, I know Dr. Dickerson and Dr. Muto, you were thinking about things as what is going to be billable versus what is not. How are we going to make money as a provider in a clinic and a center? The other side is, I think providers have also been put in the position of having to determine what type of care they're going to prescribe based off of how much it's going to cost the patient. And that's not the role of the physician.
Right.
And that burden is being put on the physician. And so perhaps the patient is not learning actually what their options are, because the physician is deciding for them that, oh, this is probably too expensive, or this is out of pocket, you don't want to do this. But maybe that's actually the option that the patient needs to hear.
Yeah, that's actually true, because women can order their own mammograms. It's one of the few things you can actually order for yourself. You can schedule, your own.
I was like,
I said not, or schedule your own mammogram. So I think that we can't ignore the direct consumer marketplace, the patients that are out there that are managing their own care, and that they, as they become more educated and access to information, that they can make those informed decisions. And I think you're 100% right. They should know what the pricing is,
And I think the whole reason that we're seeing this move in direct-to-consumer healthcare, consumerization of healthcare, is because patients aren't getting what they need by our traditional healthcare system for a myriad of reasons. Honestly, the barriers to screening are so complex, and there's so many, but it's because of all these complexities and all these items that now we're seeing such a move to consumers wanting to take control themselves.
Yeah, and I think that kind of... Yeah, well, let's take this into because the next question is related. So let's run through, the next question, which is the challenges to working up a breast cancer, which are, where this doctor makes a decision on, does this patient, need a screening study? Does this one dense breast? Does she need an ultrasound as well? There's a lot of complexity here. And I think it goes to data too on, just how useful is that ultrasound, for a dense breast mammogram? How many thousands and thousands of women do you have to image to get to pick something up that way? So, let's talk about the barriers to, the challenges in the workup and getting the patient there. And I would also say that as direct primary care comes into play, that the DPC doctor that is working with a health plan is actually looking at the patient's pocketbook, the employer's pocketbook, and trying to spend the dollars in the best way possible. So, Nancy, why don't you, take that on?
Yeah, I thank you. I think that's a perfect segue. So, because I'm a broker that still works largely in fully insured markets, some of the challenges that Caitlin was describing as far as the provider actually thinking about, oh, that's going to be too expensive for the patient, we don't see that in the large healthcare systems, at least out here in my area. They are looking at meeting their metrics that they need to satisfy their particular how many tests they prescribe, and they're not looking at prescribing the least expensive. Oftentimes they're prescribing the most expensive that they can get away with because they know they'll be paid more on it. So
Right.
I don't think they're making decisions based on what's best for the patient. I think they're making decisions based on what's best for revenue generation. And that's a real issue that we see on our side. So that's from the insurance standpoint, and I'll let you guys talk about it from a clinician standpoint.
Al?
Well, I'm with Nancy on this. And also, you know, if this is direct to consumer, as that happens, you can't just kind of throw somebody into the pool. You can't send them into a foreign country without teaching them the language. That, of course, is what we do at Quizify. And I'm frankly learning here that we're not teaching, the complexity even exceeds what we're teaching people. I had no idea that if you go in, well, first of all, if you go in, you already had breast cancer and you're getting a screening mammography, that doesn't count as a screening mammography, as I understand it. That's billable. Is that what I understand?
If they are entitled to their screening mammogram, but people look at the cancer diagnosis and upcode it immediately to a diagnostic.
That was what I thought you just said. And the second thing is,
it's not correct.
But they do it anyway. So, trust me, we live in the world of incorrect. I just got a level 5. I can't even tell you where it was from because these idiots forgot to ask for a non-disclosure agreement. Vanderbilt Hospital billed level 5 for somebody who walked in and walked out without any medication. You know, we see this kind of thing all the time. My other question, I just want to make sure I have clear for the folks who are on the call, including, I might add, myself, is if you do 2 tests in the same day and one was indicated by the other, you cannot bill for the second, whereas if you do them on different days, you can?
It depends. If, like Medicare, for example, might not pay, Blue Cross might, but they usually just generalize it to one rule. And so you just need one insurer that doesn't pay it, and then everyone suffers.
Either they have to come in twice or they get
Or 3 times.
or 3 times. All right, this I got to tell you, I'm here as a panelist, but I'm learning a lot. By the way, I still think this is done too often. Having said that, I'm learning a ton from you folks, and I got a couple Quizify questions I'm going to write based on this group.
Excellent. Okay, Paula?
So the I'm so glad this question is here. The challenging in working up a breast cancer patient, because I'm actually working up a mother-daughter right now. A mother I treated 15 years ago. Now she has a recurrence, and her daughter who has a triple negative first time. And so in the old days, in the breast center model, we would navigate them as quickly as possible, do the mammogram, the spot, the core, get the diagnosis. It would be a phone call to the oncologist literally while the patient's in my office, and I would do a personal handoff to that oncologist. And it would be the oncologist, the radiation oncologist, and the surgeon. Before diagnosis, it was the radiologist, the pathologist, and the surgeon in a triangle in the screening. Once the diagnosis was made, we moved into the oncologist, the surgeon, and the radiation oncologist, because that's how we would plan the treatment. So it was like a multidisciplinary approach, and those were personal phone calls. Now, fast forward to where we are today. Our cancer therapists, our cancer oncologists are heavily consolidated. There is no appointment maker anymore. There's no phone call that you can make. You actually have to go there and offshore. I believe Dana-Farber has an offshore central scheduling where they pre-screen you to make sure you have all the right referral, authorization, network restriction, but it's not automated. So there's a personal touch that's overseas that figures out how to navigate this patient in. The appointments are 2 or 3 weeks booked out because, again, they're booked solid, right? And so then there's that sort of delay that happens. Working up the patient, in the old days, it was kind of like you knew breast conservation, you knew when you needed an MRI. If it wasn't going to change what you did for the patient, you did not order the test. Now it is an automatic. If I don't order a breast MRI, there's going to be a conference that says I might not be meeting standard of care. Standard of care dictated by breast centers where people do 100% breast and that's all they do. So naturally, go to Midas, get a muffler, right? Every time you go, you're going to get a muffler. And so I've seen the evolution of the breast specialty Again, I trained at the beginning with the original before it was a specialty separated. It was always part of general surgery. Now it's become its own kind of siloed entity. And so they have protocols. And so you walk into a breast center, you're going to get the kitchen sink. Whether it's going to change the diagnosis or treatment of that patient is less likely. And so I like the nuanced approach. So for these mother-daughter, I got them in to see the oncologist. They went together and I texted him, what did you see? I did. He's texting me back recommendations. But it's a challenge. It was much easier in the old days when it was personal and you could navigate these patients and really order the test that was going to inform your decision. Now I feel like there's a lot of, and unfortunately, Al, you're going to go to the data and you're going to see articles in the New England Journal. You're going to see American College of Surgeons that are going to like support these recommendations for more and more and more. And you have to dig under it and see, but that's not changing what we do for the patient.
Agreed. And so
yeah,
Caitlin,
absolutely.
Caitlin, has a product called Gabby, and I see several areas here that we've discussed where it could be helpful and get people on the right track, not in a data-driven way. Caitlin, you want to kind of fill in on that?
Sure, absolutely. So I'm sure everyone on the call is familiar with the Tyrer-Cuzick or IBIS or Gale risk model, and what we did was we looked into all the different specialties that are or are not using the existing risk assessment tools for breast cancer today. And what we found is that most often the only place it's being done is if you're going to a high risk clinic and seeing a specialist who's using like the Tyrer-Cuzick model, or if you're going to an imaging center. But oftentimes, one, the specialist can be difficult to get to, hard to access, expensive. And there's not that many around. And often by the time they get to radiology, it's too late because either the wrong thing has been ordered for them, or they had a higher risk. And so they should have started screening much earlier. And now they're going for their first 2D mammogram. So we created a better risk assessment ultimately that is able to predict risk for women of all ages, all ethnicities, and is able to predict risk at higher accuracies than the Tyrer-Cuzick and the Gale. And we put it in the hands of women because we saw that providers today, there's an unending list of things that are supposed to be addressed in a patient visit. And so one more thing, whether or not it should be done or shouldn't be prioritized, one more thing is just, it's not feasible. And so by putting it in the hands of women, we can ensure that women are learning their risk. And then equipping that with access to breast specialists so that the breast specialist is now learning about their risk level, is sharing it with their PCP or OBGYN. And then as a breast specialist, we're able to prescribe the right screening at the right time.
Excellent. Well, and then finally, I think we know about the traditional, that we've been able to do some testing, genetic testing for breast cancer specifically, but there's some new products coming out like Grail that, can search for multiple cancers, including the most common cancers. And so, I do, the New England Journal article about colonoscopies and, that may not be, now again, you have to look at what you consider an outcome, but that the people who are getting them and are not getting them are, have similar outcomes. And then, but how do each of you see something like Grail fitting in, that's screening for multiple cancers into this formula / algorithm of breast health? Nancy?
Sorry, I had to unmute myself. I am personally all for it. And I think that anything that we can do, again, to gather more information, I don't think it's a standalone solution, but it's additional information that equips providers and patients to ask the right questions, to order the right tests, and to be aware of additional factors that may come up. I think genetic testing is one of those areas that we are going to see increase over the next 5 years. And I think it's a good thing because especially when we're talking about cancers as well, then we can target treatments for it as well if we know the genetic makeup. So I personally think that it is going to be one of those things that there is going to be a cost associated with it, of course, but I think the benefits are going to far outweigh the cost and ultimately potentially even reduce long-term costs of treating things like breast cancer.
Excellent. Al, what are your thoughts?
Well, you know, I've been over it up, down, and sideways, and it does seem like a game changer to me. And frankly, I think it's a little bit like there's an analogy in the area of dental care, filling cavities, where there's a miracle solution called silver diamine fluoride that you put on the cavity and it stops it, and it costs $30 and takes 2 minutes. And I have it in my own mouth, and it's amazing. It's safe. I did it in the same visit that I did my checkup in. And the dentists are saying, well, this is a nice alternative to filling cavities. No, it's not an alternative. It's a replacement. Your revenues are going to go way down. I'm sorry about that. This is simply a much better offering. As far as I can tell, and I'm willing to wait a few years on this, I think this might be a replacement product for any sort of average level, not the high risk folks that you all are talking about, but any average level person's risk for essentially any cancer. And yeah, it's going to cost money, and employers are going to have to cover it, and then they're going to have to cover follow-up care. But I think that, well, first of all, so few people have cancer that it's not going to be a lot of care. And as Nancy said, it's going to happen earlier. But second, there's a lot of money to be saved in not doing colonoscopy screenings and other types of screenings. So I predict in these things always take 17 years, but I predict in 3 or 4 years, this or analogies or possible improvements on it might be the first line therapy.
Yeah, and I agree. And once again, money comes into play because, you know, we know very few people who are doing colonoscopies are recommending Cologuard instead. I mean, you know, it's counter to the way their practice developed. So I think, you know, we have to go ahead.
Oh yeah, no, I want just to build on that point, which is that the silver diamine fluoride, have any of you even ever heard of it other than people who've played Quizify? No, of course not, because the dentists aren't telling you. They all know about it, but what we teach in Quizify, and it's not just it's FDA approved, it has breakthrough therapy status from the FDA. It's the highest approval of any dental intervention whatsoever, but you have to ask for it. And what they will tell you, as my dentist did, is they say, when she said, oh, you have a cavity, you know, we have to make an appointment, we'll fill it. I said, why don't we just use silver diamine fluoride right now? She said, well, you know, we could do that. She said, curiously, nobody ever asked for it. Well, of course, nobody ever asked for it because they don't know it exists. So yes, you're looking at you know, sort of a revenue model that's been built up over time to do certain screenings, not just the revenues, Kristen, but also this is what people were trained to do. Dentists were trained to fill cavities. They weren't trained to just paint something on your tooth. Radiologists trained to read to read mammographies. They don't want to give that up.
Agreed. Paula?
So with any kind of genetic testing, that you always should think of the false positive and and the false negative, right? So I'm all for absolutely being more what I call precision medicine, understanding people's risks better, but the risk doesn't mean the disease. And I think we saw this with BRCA testing. Patients would come in and say, I'm BRCA, take both breasts off. It's like, okay, let's talk about that. You know, like, or lobular carcinoma in situ. When a patient had lobular carcinoma in situ, it was a disease that could occur in both breasts equally. It's not even considered a cancer anymore. But for years, people were offered either do nothing or take both breasts off. I mean, it seems like a rather crazy thing, but if you pulled it all back and realized you weren't making people live longer, it didn't change your survival. Your likelihood of metastatic disease with BRCA, it doesn't reduce when you remove the breast. It just means it doesn't occur in the breast, but it could occur somewhere else because it's in your genetics. So these conversations become more complicated, and BRCA doesn't mean you're 100% going to get breast cancer. You know, it means you have 30%. It's like, well, that's not 100%, right? You're 15% coming out of the gates being a woman. So it's like, so you sort of have to put the risk relative to the risk of being a human, being a woman, and being over 50. So I think that when you look at these genetic tests, you have to put it in the screen of how much increased risk that you have relative to the regular population, and then weigh the risk benefit. I think that at the end, there's no question screening will be great, but we're going to head down a path of some false positives. And then of course there'll be the false negatives. You're negative, you're not going to get this. And that you're going to give people false assurance that you're not going to get a BRCA breast cancer, but you could get another, you could still be at risk for like non-genetic breast cancer, which is the majority. So these are the kind of things where I think data and technology will help inform these decisions. But I think we have to proceed with caution, thinking like everything needs to be treated, because I do think that that's where, where that negative colonoscopy actually prevents you from doing something potentially more invasive because of what you had on some type of screen that puts you at a risk. But that's kind of, I'm speaking as a clinician.
Right. And great points. And then the other factor we have, because many doctors have zero expertise on this. We also have the emerging secondary providers who will have even less, knowledge base of how to handle, positive tests and the workups. So I think there is some risk there. There's also pre-existing condition, with a false positive, am I going to develop this cancer 4 years down the line? Is it going to become? And so, I think there are a lot of factors there that we do have to consider on the negative side. Caitlin, what are your thoughts?
I actually had a question for the clinicians in the group, because in many circumstances, we are actually selling to some of the same people that Grail is, like employers. And I frequently get asked by employers what our stance is on Grail, but I'm curious, what level of validity, efficacy, or outcomes would you be looking for with something like Grail? It's rather new on the market. It's not just a genetic test saying, yes, you have a BRCA mutation, or no, you do not have a BRCA mutation, which has become very widely accepted as something to do if, someone meets criteria to test them for a genetic mutation. So what would be the level of efficacy and outcomes that you'd be looking for, especially because some of the things that they are highlighting aren't actually actionable? So I'd love to hear from the clinicians.
Well, I think we've got to do long-term studies, with anything like that. If we're going to say that there's an outcome on mortality and morbidity, you have to gather so much more data than really we have at present. And you've got to have that temporal spread to prove it up. So Paula, what are your thoughts?
Yeah, I think that, like everything as a clinician, okay, so you have a genetic risk for some type of pancreatic tumor, something comes out there. But oh, by the way, you have also like 3 vessel heart disease, diabetes, and obesity. So I'm like, at the end of the day, like, you have a medical history and an outcome that may not be solely driven by whether or not you have cancer or not. We do know age and cancer go hand in hand, so we're probably going to see a lot more, but I don't know enough about Grail and the data to know, does it predict your lifetime? I mean, look, prostate cancer, you don't need Grail. 100% of men over 80 have prostate cancer. Do they die from it? Maybe not. Do we stop screening for it? No, we don't. Because when we did, we suddenly realized, wow, we were delaying diagnosis on early stuff, and now we're stuck with the hard stuff, because whoever thought people were going to live to 102? So I think that cancer we're going to see more of, because people are living to 102, and you just have to, and Grail, if can tell me they're going to get it at 30 or 50 or 80 or 100, if they could say that, that would be great, because then we don't have to take care of this. We don't have to worry about this one.
In my understanding, it's a particular point in time. But Al, I think your hand was up first.
Oh yeah. So I have looked into this Grail, and skeptic that I am, I was trying to find all the things wrong with it, and as you said, Kristen, we need to wait this one out, because oftentimes things don't show up until later. But I got to tell you, and I'm somebody who thinks most of this, almost everything that people sort of market it, to make money on in healthcare I'm very skeptical of. This one actually seems to have some, and it's not a risk thing; it's an actual cancer thing. Now, do you treat it or not? Well, if I personally don't get my prostate checked. I don't get any screenings at all, because I'm so screening literate here. Now, I'm not a woman, But I do the Cologuard. I do the Cologuard, but I wouldn't dream of getting a colonoscopy unless that shows up positive. This is different. This actually shows you whether you have cancer, not whether you're at risk for cancer.
Right. Nancy?
Yes. Well, I have a question actually for the panel, and then, and I don't know if you wanted to address it before my question, but Chief Smith made a really good point about men and screening for breast cancer. So I don't know if anybody wants to address that first, and then I can come back because I don't want to let that one go.
Paula, do you have
I have one patient in my practice with breast cancer, and I've taken care of a lot of young men with, small adenomas behind the nipple. A lot of like marijuana use can cause gynecomastia, and they can get these little adenomas. But I had one guy with breast cancer. So that's in my practice of 25 years. I'm not obviously referral center for it, but there isn't really any. Because of that rarity, I don't think there's a screening for it. But I don't know if anyone, I don't know if you've seen any more than me, Kristen.
No, I really haven't. We usually see gynecomastia in that setting. I've had some patients who've been treated for, cancer return, but I've never diagnosed a male breast cancer.
So we actually get this question quite a bit of, can you assess risk for men, or do you have support for men? And so I know this data for every one male that's diagnosed with breast cancer, 16,000 women are diagnosed with breast cancer. And so it's really,
yeah. Right. Well,
can I go back to my original question now?
What was your original question?
My original question is again for the panelists, and it really has to do with virtual direct primary care. And what do you see as the appropriateness of how they're ordering testing around breast cancer screening?
Well, I'm going to take this first as the radiologist, and that is that with telemedicine in general, there has been a dramatic decrease in ordering all types of diagnostic and screening exams. And it has to do, again, with the financial model. The same guy is not going to be there 4 days later to get the abnormal report and manage it. And so if anybody needs imaging, from what I'm understanding, the telehealth, they're sending them back to a specialist or sending them elsewhere. So I don't think telehealth is in general doing that, but when it's a direct primary care telehealth, and there's an investment, they're only going to be on the plan again next year if they, show that they've provided better care, better financial outcomes, better health for the employees. I think that's a different model than traditional telehealth. And I think there is a vested interest in making sure that those exams get performed and followed up on. So in my practice, where I do deal with both, I deal with regular telehealth and I deal with DPC telehealth. I find that DPC telehealth has systems in place to get that, normal or abnormal report back and get that information to the patient. So Al, what are your thoughts there?
Well, I'm agnostic on what you said, but what I would tell you is telehealth. We've identified at Quizify, we teach people that there are 3 specialties that dramatically overprescribe antibiotics. And of course, we go into why you don't want to take too many antibiotics. One is telehealth. If you want to guess what the other 2 are, in the interest of time, I'll probably just tell you, but it would be a good trivia question. Pediatricians and dentists dramatically overprescribing antibiotics. So I'm not a huge telehealth fan. Now, it may be different in a DPC model, but the general sort of pick up the phone and call telehealth and get on the line with a physician in 15 minutes. They want to solve something, even if there's no way they're going to know whether something's bacterial, but they're going to give you an antibiotic. That's the only thing I can add to this conversation.
Okay, Paula?
So I, again, train family practice residents and surgical residents. And one of the things that frustrates me is that and I've seen this amongst primary care physicians too, they think they can just order a mammogram and that's going to check the box for your breast health. Okay, women physicians can go in the room and take off a bra and examine a breast. without a chaperone. And it might be because of that male physicians feel like they, it's going to cost more, whatever. I don't know if it's a male-female thing. Telemedicine for breast exam. I mean, look, medicine is a contact sport. There are many times that I have had a negative mammogram and have found something on an exam. And that isn't just, oh, Dr. Muto, you're making that stuff up. It really isn't. And it goes back through centuries, because everyone who trained me says the same thing. Breast cancer, you're wrong 15% of the time. And I said, you're right. Like, in other words, you feel something, it's something and it isn't, or you feel something, you think it's nothing and it is. So it's just the way it is. And I think that the tendency has been to order tests. The tendency is not to see patients. The tendency is not to get bra off. I mean, I had a woman that literally came to me, and she was like an older woman, like in her 85 or something, had gone to the ER in chest pain. They put a stethoscope on her chest. Okay, went to her primary, they put a stethoscope on her chest. And then nobody actually bothered to like undo her shirt to notice that she was bleeding through her bra with a stage 4 breast cancer. Like, how did you like miss that, right? But this is unconscionable to me, because that's the fundamental part of medicine. So telemedicine is nice to connect. Like, if I can see my cancer patients this way and follow up, can I talk to them? But honestly, you need a breast exam. It's part of the deal. Sending them to radiology just to get a mammogram, the woman is still getting examined with a machine. I said, so I just think that piece of the equation has to be there if you're going to bill for it. If you're going to bill for it, it should be there.
And Caitlin.
I love hearing that. We had a similar experience recently where a patient actually had a breast lump, and she didn't even have to lift up her bra to reveal this very large mass. And she had seen her primary care provider, and like, how did that not get identified? I think transparently, I'll share, we're all virtual, and we send patients to get in-person clinical breast exams, and of course, any of the necessary screening. We're trying to figure out how to incorporate the contact portion of needing to palpate a breast lump, while also leveraging as much as we can digitally to ensure that we know the patient's risk, and therefore we're prescribing and ordering the appropriate screening. But we also believe that the mass has to be felt. The woman has to be touched.
And I'll tell you, when I started in a breast center, after 7 years of surgical training, and I thought this is great. And the head of the breast center said, it's going to take you at least a year to learn how to examine a breast. I'm like, what are you talking about? I trained, it took me like 2. She was 100% right.
Wow.
Because it takes years to really do a good breast exam. And then, so the utility of a breast exam, there's a great study out of Canada where they had like a nurse practitioner or something examining breasts. And they realized that a really good breast exam was really offered the same sort of survival benefit as doing screening, but it was one person who was exceptionally good at breast exams.
Right. And I would say that the radiology technicians, when you're positioning a patient for a mammogram, you get and I can't tell you how many rad techs have told me this patient has a cancer. But
wow.
When they bring the images across to me. So
Sure.
We are nearing the end of our time together. I have really enjoyed this, Al. I've learned things as well. And, I really want to make these panels that are kind of where we look at data, we look at health benefits, we look at, clinicians who are actively involved. I want to do more of this, because I think this is how we provide better health care. So, this has been recorded, and we will, get it out on social media. And you all have all provided great information, great insight into this topic. And I think we're going to be better for it. So thanks for being with us. And you all have a great rest of day and weekend.
Thank you, Kristen.
Thank
so
you
much
for
for
having us.
organizing.
Thank you.
Sure.